of the Collaborative Center after today's gathering. Today we have Dr. John Appleby presenting, and I will introduce him shortly. So the format of today's session is he will speak first for about 30 to 40 minutes, and then we'll have 20 minutes or so afterwards for Q&A. And that includes both online and in the room. And so I'm really grateful that we will have some support to moderate that so that those of you who are joining us online will have an opportunity for your questions to be addressed during today's seminar. So let me move forward then to introducing John. So John is a philosopher, so am I. So I'm delighted always to have philosophers join us at Lancaster Medical School at Lancaster University in the UK. He is director of the PhD program in medical ethics and law and co-director of the medical ethics and law teaching theme for the medical degree program. He studied bioethics and philosophy at the University of Toronto and at New York University before completing his PhD at the University of Cambridge. He is currently pursuing two streams of research: the ethics and regulation of environmentally sustainable healthcare and the ethics and regulation of biotech innovations, especially with respect to reproduction. So, John, thank you so much for joining us, especially joining us in person today. We are all been actively looking forward to your arrival and look forward to what you have to share with us today.
Wow, well, thank you so much for the introduction, Professor Gibson. And I just want to thank the organizers, Professor Miller, everyone at the Collaborative Center and the Joint Center for having me today. It's an absolute pleasure to be here to share this research. It's something I've been chipping away at for a while, and so I always look forward to the opportunity to share it and get some feedback. Thanks to everyone who's come in person and online as well. So what I am going to talk about today is this question of what the healthcare exceptional objection is and how we respond to it. Just going to jump ahead. And I will say that this research has been generously supported by my university, Lancaster University, the UK Institute for Medical Ethics, and Research England with the UKRI. So I'm going to just start by giving a little bit of background as to how this even came up before I even get into the nitty-gritty of the actual presentation itself, which will aim to address this. I've always been interested in sustainability and healthcare because it seems to pull in two different directions. In one way, we're trying to help heal people, but at the same time, when we're trying to help heal people maintain their health, we could be harming them by harming the environment. And so I was delighted in the UK when the medical school I work at, but more generally in the UK, it became a requirement to teach all medical students about healthcare sustainability. And this included ethics and law. And so I went about researching the topic, I built up a curriculum, and I started teaching it to my students. And it happened to be one of the first curriculums in ethics in the UK. So I took the opportunity and I started teaching it to other med schools as well. And a lot of the questions that the teaching was throwing up, I thought, gosh, these are legitimate research questions on their own as well. So I started, this was probably almost 10 years ago. Now, wow, time flies. I started researching this as well, partially so I could keep doing good quality teaching to my students, but also it was just really intellectually interesting. And I was talking to people, both my students, other teachers, and researchers about how we might go about integrating sustainability into healthcare. And I thought this was fine. We're, doing my philosophical work. It seemed to be quite foundational in nature. Wasn't a really, really busy space at the time. But increasingly, I started confronting a real problem. As I would give presentations, as I do my teaching, I came up against an objection that I really wasn't sure how to deal with. And people would phrase it all different ways. Some people quite gently as, I'm really not sure healthcare needs sustainability. It needs sustainability. Healthcare has so many pressures on it already. Do we really need to bring sustainability into the mix? Whereas other people would be a little bit more forceful with a kind of get off my lawn kind of mentality of keep your green agenda out of my healthcare, whether it was healthcare teaching, whether it was healthcare ethics or healthcare practice. And so I thought to myself, I really need to I need to confront this objection, try to characterize it in a way I can deal with it, discuss it with people. And I also need to come up with some attempt at figuring out approaches to it. So that's really how I get here today. It's out of, in many ways, necessity, very practical problem I faced. And at the very least, my aim today is to put this very initial attempt out there for other people that might come across the same thing to engage with. And hopefully over time we can build up a richer and richer approach to this. So today's talk is going to start with a bit of background information from me on sustainability in healthcare. And I appreciate there's actually probably quite a lot of experts online and there's experts in the room. But in case anyone else is coming to this new or watches it later on YouTube, you can see a little bit about the context that primes the dilemma that I arrived at. Then I'm going to deal with this dilemma of what is the healthcare exceptionalism objection, try to outline it, define it, and then in part two, discuss how we should potentially respond to this healthcare exceptionalism objection. And then I've started sketching out some next steps along with the summary. So even if I just achieve this much, hopefully it opens it up to other researchers that can keep pursuing it. Now, what I'm about to go over really just scratches the surface of all the information out there that might be available to characterize sustainability in healthcare. But here's some of the basics that I found to be really useful when organizing it and thinking about it, especially in relation to ethics work. So it's actually not an overstatement to characterize healthcare as one of the most environmentally destructive industries on Earth. It's a brutal thing to say, but when you add it all up, it is a major problem. This environmental destruction can be generalized into at least three categories. You could split it up in other ways, but at least three. I find it helpful to think about gaseous waste. So, for example, greenhouse gases, solid waste. So it might be the plastics that you consume as a patient, could be a lot of other things. And then there can be chemical and pharmaceutical waste, and nuclear waste can fit across at least the last two categories. And in terms of the scale, there's lots of metrics out there, but one that's regularly used is that healthcare's climate footprint is approximately 4.4% of global net emissions. However, I think some of these characterizations are a bit problematic because the data we have to make them is still very rough in some areas. So we just have to kind of look at generalizations at this point. Now, for solid waste and chemical pharmaceutical waste, we also have incredibly weak data. And I'm going to touch on why this is later, at least in the UK context. So I'm working in the UK. I thought it'd be interesting to at least show a little bit of the context from what's going on in the UK, as they've been quite aggressive on the sustainability front. So I'll use that as a case study. But clearly, there's quite a lot going on in Canada, Australia, the rest of Europe globally. By no means is this the entire picture. But if we look at this weak data, and the UK alone, estimates come in at something like 156,000 tons of clinical waste per year. But this is almost certainly too low based on all the data that's missing. And I think what's really important is that climate is incredibly crucial to how we think about this, but indeed, sustainability in healthcare goes beyond just climate, and it pertains to a whole range of ecological areas. So when we think about the cost of healthcare, this can also be measured in how we consume living and non-living resources that are part of ecosystems. So two interesting cases that I think are worth flagging is there's the case of the Pacific yew, which was almost driven to extinction through harvesting in order to derive compounds used for cancer treatment, Taxol. And it's only recently that in history that attempts have been made to stop this, actually ensure that these forests and the ecosystems that surround them are not completely wiped out. But this was mainly driven by healthcare. And of course, other species of yew in the Himalayas and so on were also affected. This is a global problem. Interesting, I actually just randomly learned about this at info panel on the wall of Van Dusen Botanical Gardens in Vancouver. So just everyday healthcare sustainability learning. Another example that I think is very interesting is the fact that in order to ensure many of our medicines and vaccines are safe, we still to this day rely on harvesting horseshoe crabs every year, draining about half their blood, and then using compounds, a protein in this blood to identify toxins, for example, in our medicines that could be harmful. So to test the safety of our drugs. Now, these horseshoe crabs are released. We don't really understand what happens after this process, but it goes to show kind of the industrial use of the environment without much knowledge. And what's interesting in this case as well is that we have a perfectly good artificial substitute that could replace this, but we still do not necessarily do this. So another example beyond just climate, although everything is all linked together. So we can summarize here just some basic things that are happening, in particular in the UK. Efforts are being made to make healthcare more environmentally sustainable. The NHS, for example, plans for net zero. There's quite an aggressive plan for direct carbon emissions by 2040 and net zero for indirect carbon emissions for 2045. Greener NHS has been set up as an arm of the National Health Service to lead this program of change. And as I mentioned before, this attempt to make healthcare more sustainable has trickled down within the regulation of medical students to actually, in terms of their training, to make sure that they are actually trained in sustainable healthcare. That's something, again, I'm working on. Environmentally sustainable medicine is an emerging global concern, and it's important to note that everything from medical societies, governments, regulators, and also clinicians and patients are taking action on it. So it is happening on all levels. Now, whether it should happen on all levels is quite contested. We'll talk a little bit about that later, but it is happening. So at this point, we can at least reach the point of agreeing, hopefully, that action needs to be taken to make healthcare more sustainable. It's kind of basic assumption I want to start off with. And I personally find it really helpful to think about the different levels that it can happen on. Again, this is contested by many who think it should just happen on one level or the other, but this is a common approach to first think of things industrially. And this would almost be a systems-based approach. So you could think of it like the industrial education of all medical students in the UK. Although we don't tend to think about medical schools that way, that's one way of thinking about it. The industrial manufacturing of goods used in healthcare, and then potentially developing industry-wide sustainability standards. So kind of multi-dimensional way of thinking about an industrial level. Then you might think about an institutional level. So maybe local hospitals, hospital networks like here in Toronto. And then you might also think about things at the individual level. So how can sustainability happen at the individual level? So between, for example, healthcare service providers and patients. And that is how I'm approaching it, thinking about these three levels. So a few other concrete examples here. In the UK, attempts are currently being made, for example, in operating theaters and so on, to capture anesthetic gases that might leak out during treatment. There's quite a lot of decisions in England that are being made from the top down at industrial and institutional levels to try to create change, for example, encouraging green inhalers. Almost all responsibility to change, however, and this is surprising to many people, actually falls in England to what are known as integrated care systems. So local groups that decide how money should be spent in a region. And so despite decisions being made potentially at the very top of the National Health Service, much of the decisions are still being made much lower down. And they are the ones that are responsible for planning and delivering services locally. This is actually because it's still the case in England that data is held in data silos. So the NHS can't actually accurately make all of the top-down decisions it might want to make because the data is being held in these integrated care systems in terms of what is consumed, what is needed, and everything else. So I only mention this because one of the major objections that comes up in sustainable healthcare is that why are you spending any time with anything, any decision-making that's not at the top? This is purely a top-down decision. In places like England, it is simply impossible based on how it's structured. So this is how it's happening. And as a result of this, quite a lot of decisions still are happening at the doctor-patient level. So individual clinicians are having to make decisions about how to meet the NHS's net zero goals. And so you have a huge plurality of different approaches that are going on. And so it's still viewed as really important that doctors have a very granular understanding, at least in the UK, of how to be sustainable. So I just thought kind of address that objection as I go along. Now, another thing that we have to understand here is what is healthcare? And my approach is a very broad approach of healthcare, because we'll talk about healthcare sustainability. Well, what are we talking about? So this is the entire system of creating, providing, and consuming healthcare goods and services. Now, there's all kinds of work where you could split it up in relation to different projects, but for the purpose of this talk, I want a really broad conception. So this could be everything from manufacturing a vaccine to, putting it in a patient's arms, throwing it away, processing it, hopefully not dumping it illegally, but we've seen that happen. This can refer to industries, institutions, individuals that take part in, including the patients. So I want to have a really broad conception at this point. It does mean that there's a little bit of vagueness that goes with that, but I think we need to encourage as much as possible to be included at this point. And then in terms of what is sustainability, environmental sustainability, I'm really just looking to have this as sustaining an environmental state. But this can also be pretty broad. It could be something dealing with, pertaining to net zero. It could be not wiping out a species like the Pacific yew, sustaining a desired environmental state. So, I'm teaching all this information to my students and sharing it at conferences. And I devised a principle I thought I could at least get the ball started with students with, this principle of environmental beneficence, a way that, again, these clinicians in training, they're going to go into their practice, and how could they talk with patients about it? So I devised this principle that states that when healthcare decisions are being made, priority should be given to whatever course of action would bring about the most environmentally sustainable outcome, while also sufficiently meeting the health needs, and this is an important bit, respecting the important life projects of patients. So this, I'm reading it verbatim so I don't miss anything. This allows for decision-making to be adapted so that in instances where a healthcare decision involves a trade-off between maximizing environmental sustainability and patient needs, there's scope to make different decisions between varying needs of the different patients and their own notions of a good life. Now, what's really important here is I'm trying to make space for decisions that are not necessarily linked to removing low quality care or simply based on care. It could be based on a person's ethical preferences for consuming different kinds of goods that are in many ways detached just from health outcomes. So for example, there are examples where some patients have decided they did not support the nuclear industry and therefore did not want products from nuclear medicine involved in their treatment, despite it being attached potentially with a better outcome. Now, when I came up with this principle, it really kicked things off in terms of triggering a lot of people to say to me, well, I object to this. They said, really, do not burden healthcare at any level with concerns of environmental sustainability. It was put to me in no uncertain terms by some people in the in different audiences that Healthcare is special. It is exceptional to any rule you might come up with, including any policy, attitude, project you might have about environmental sustainability. And when this came up the first time, I was giving a talk at a UNESCO bioethics conference, and they had a really amazing audience. And it came up, and I thought, well, this is a serious objection I need to deal with. I didn't have an answer immediately, but then it just kept coming up, and I thought, okay, we really have to deal with this because it's is a widely held concern. So what do we make of this objection? How seriously do we take it? And this is where we get to part one, which is how do we, in order to decide whether or not we take this objection seriously or how we weigh it, we first need to figure out what it is. So I've tried to characterize this in as simple terms as possible. What is the objection? How do we characterize the healthcare exceptionalism objection? So the most basic structure I can come up with is healthcare is important to promote human welfare and flourishing. Environmental sustainability interventions in healthcare may threaten healthcare's ability to be delivered in a way that allows potential health benefits, broadly construed, to be realized to a desired extent. Therefore, should society treat healthcare as exceptional and either avoid society should treat healthcare as exceptional and either avoid or minimize any burdens placed on it for the purposes of achieving environmental sustainability. Now, when this came up, I thought to myself, surely these folks that are making this objection are relying on a pre-existing objection in healthcare that maybe I just failed to look up so far in my research. I was familiar with the fact that there was lots of instances of healthcare exceptionalism in the literature, and so I went looking. So, of course, we're already familiar that exceptionalism is been an attitude for a very long time. In medicine, we have Hippocrates, we have the Hippocratic Oath. If we wasn't exceptional, we wouldn't need that. It's obviously the very least an attitude of being different from the norm. Now, Sir William Osler is a excellent resource when thinking about how people might have thought healthcare was exceptional. So his biographer, Michael Bliss, actually wrote a paper on his attitudes to healthcare exceptionalism, which is great for anyone interested in this. But he had some interesting quotes that I thought kind of characterized some attitudes. So this idea that it represented an exceptional achievement for humanity, stated in a little more than a century, a united profession working in many lands has done more for the race than has ever been before been accomplished by any other body of men. He characterized it as man's redemption of man. I think it says something that even someone who was a bit skeptical, a historian like Roy Porter, even named his book The Greatest Benefit to Mankind. But there's many other examples within healthcare of exceptionalism. So there's research exceptionalism, genetic exceptionalism, HIV exceptionalism, even there's many different points and versions within that, psychedelic exceptionalism, biospecimen exceptionalism, and the list goes on. So there's quite a lot of work on this, but none of these versions of exceptionalism really characterized what I was coming up against when I was sharing my work. And so, hence the need to come up with the definition provided. So even the definition I provided, it seemed too clunky to me in the most basic sense to characterize the different approaches that could be taken. Because to me, it seemed that even though I thought sustainability was an important thing, there was still something to the fact that healthcare was special. It did an important role in society. It couldn't just say get lost. It's not exceptional. So how can we balance this out? So to me, it made sense to try to characterize this. Whereas healthcare deserves to be treated in an exceptional way, but it's different from other forms of exceptionalism. This refers solely to debates about sustainable healthcare, and I categorize it as hard and soft healthcare exceptionalism. So hard healthcare exceptionalist position is one that would resist any interference from healthcare sustainability considerations, in relation to any given aspect of healthcare. So it's a really absolutist type of position. According to such a view, all resources and activities should be focused on healthcare, regardless of extreme consequences to the environment and the existential risk to humanity. As one person put it to me, I don't mind if the world burns up and turns to dust, as long as you don't interfere with my healthcare, it's fine. However, more moderate position, soft healthcare exceptionalist position, would say that the environmental sustainability concerns should not intervene on the project of healthcare to the extent that it no longer fulfills its function of delivering healthcare goods and services to society. So it's very much a compromise in that way. It could potentially be viewed as some sort of compatibilist position. So with that kind of definitional foundational work in hand, I thought, how should we respond to this objection? What can we do with this? So we go back to the question of how much weight should we give this objection when determining burdens that should be placed on healthcare to be environmentally sustainable. And so what I want to do is test an argument here that I've put forward, a thesis. So I argue that healthcare should be treated as exceptional insofar as it should not be overburdened with the demands of sustainability, again, to the point at which it no longer delivers on the health needs of those it serves. However, this does not mean that healthcare should be treated as exempt from the urgent need to become more sustainable. So healthcare should do everything necessary to reduce its impact on the environment while also ensuring these sustainability efforts are balanced against providing healthcare goods needed for patients to lead a flourishing life. And this thesis really, it aligns with the soft healthcare exceptionalist position. Now, what I want to do as I wrap this up here is go back to these three levels I was talking about before, about how the exceptionalist objection might emerge at these levels and how we might respond to it. And then I'll outline some of the things that we still need to do. So at the industrial or industry level, again, this deals with the broad reaching groups of governance, provision of healthcare professionals and healthcare goods. You know, you might think about the pharmaceutical industry as a whole, and so on. All of the infrastructure that might be needed within the healthcare industry, hospital networks, and so on. So the objection at this level that I've heard is that attempts to improve sustainability may detract resources away from crucial industrial projects of biomedical innovation. So an important point to make here is, outside of just healthcare, there's also a big push just for sustainability within scientific research. And there's concerns that this could kind of leak into that area as well and slow down or get in the way of scientific discovery. So they wouldn't want crucial industrial projects for biomedical innovation to be affected. You know, some have argued that training and oversight of healthcare professionals shouldn't be affected. Doctors in training have enough to worry about. They don't need to worry about saving the environment. And just the general project of resourcing safe, efficient, and effective care is enough. We don't need sustainability concerns. So I thought I'd put out this example of some people that I work with in the UK, which I think have highlighted that we don't need this hard exceptionalist, watertight understanding. We can let some sustainability into the industrial level of healthcare and not actually undercut the things people were worried about. But there's way more examples. So if we take a soft exceptionalist response that allows some sustainability in, these folks at Thermal Compaction Group, what they do is they gather up all the plastic stuff like curtains and masks in hospitals, and they have something that looks like a big fridge. They put it in there, it melts it down, sterilizes this, and then they can use these large blocks of plastic through 3D printing and other manufacturing to make more healthcare goods. So you can kind of build a circular economy based on this. This has been proven to not really burden or get in the way of anything, but it's just a simple intervention at the industrial level across systems where you can have a positive change. So I thought that was an interesting real example of this. The institutional level, Again, I'm referring to things like clinics, hospitals, individual healthcare companies. There's a range of objections that come up with sustainability interfering there. So the idea that sustainability burdens could affect the financial viability or competitiveness of an institution. I think this is a legitimate concern. Margins might be slim to begin with, and how can we make sure it doesn't, cause businesses, for example, to fail? This is an area where you could have government subsidization to help affect these types of changes. It doesn't have to happen in a vacuum. So that was just one potential way. These are practical responses, for example. People have argued that a one-size-fits-all sustainability agenda might not work for all different institutions. This is really a regulation type question where you could work with regulations to accommodate for things proportionally. Other people, I think, make an important point that sustainability is just not the most urgent priority for some institutions and communities. I think what's important if we flip that is you can still address those priorities, but they don't have to be, these communities don't necessarily have to be excluded from sustainability. Work can still be done there. And then finally, some institutions are simply much less sustainable than others. So one size fits all in terms of approach of all different areas of healthcare, for example, don't make sense. But again, to me, these clinics could still benefit from innovations, even if the savings are less. So these are many of the objections that come up are highly practical in nature or purely empirical, but we already do have solutions for them. And then finally, if we think about healthcare service providers and patients, really at the level of individual healthcare provision, folks like Richard Armitage have argued, I think it was in the Lancet, that medicine is definitely hard enough without having to worry about sustainability concerns. And there's one of the concerns he writes about is that adding sustainability to a physician's workload, for example, will be what breaks the healthcare system. So just don't even go there. However, what I would counter is we've added all kinds of things to the healthcare system and negotiated this. Informed consent wasn't such a big part of what we did at a time. And one of the arguments was that there really wasn't time. Well, we've come a long way on that. It's not solved, but we've come a long way. Another concern is that sustainability interventions will compromise the standard of care for patients and put doctors at legal risk too. This really comes down to something where top-down regulation and standards can help individual healthcare providers make safe decisions. It is concerning if people make things up without the necessary oversight or accreditation to do it safely, but we know how to negotiate that, and it can be done. Another concern that I've heard come up is that patients could be discouraged from seeking care because of the burden or guilt of sustainability concerns. This has come up actually anecdotally from doctors I've spoken to with their patients. They actually do have patients that have said this, that patients trying to reduce the amount of care they've had, potentially against the benefit of the outcomes. So to me, that really comes down to a proper discussion with the patients and trying to encourage them not to feel guilty. The final thing builds on this, and that sustainability could compromise informed consent and unnecessarily burden private doctor-patient interaction. So the concern would be that doctors are trying to paternalistically push a sustainability agenda in a way that might undercut the quality of care. And this was one of the concerns, again, that was initially raised with me, is I don't want a doctor driving a sustainability agenda that might undercut my quality of care. So this is really, I think, about educating patients and building that trust to begin with. But many of these objections are legitimate. It's just we need to address them, and they can be addressed. So just to summarize, I think this healthcare exceptionalism objection is real, and it's emerging increasingly in this debate. To my view, soft healthcare exceptionalism appears to be the safest way to take seriously concerns about the impact of sustainability burdens on the provision of healthcare, while also accommodating sustainable interventions. Nevertheless, there are still other lingering things, and this isn't even an exhaustive list of questions and objections that need to be addressed. So I think there's more work to be done on this. One point is that it's a really westernized view of healthcare that I've put forward. And how does this, for example, fit with Indigenous perspectives on health and the environment? One of the bigger questions here that would help shape some of this discussion is a discussion about the goal of health. It's one of the reasons I put in patient preferences as opposed to purely health outcomes, is that there are different goals competing there, and that will affect how we talk about things. There's the larger question here about justice and whether these concerns are actually realistic priorities for countries or communities where there aren't even necessarily resources to provide the necessary healthcare to begin with. And I'll also add that we also have to be aware of the fact that some of our sustainability efforts can sometimes land on the doorstep of some of the least privileged members of society, especially when it comes to waste processing. We saw this especially at the height of the pandemic, and it's a murky area. It's an area of concern. And then the last point would be that I think it'd be really interesting to think about what a public health approach to medical sustainability would offer this debate in particular. I think that's a really rich area that we could explore even more. That's everything for me. Thank you so much.
Well, great. Thanks so much, Sean. And we've got 20 minutes. We are blessed with 20 minutes for conversation and discussion, both in the room and online. And so what we'll do, I'll just remind folks that if you're in the room, raise your hand. We'll sort of invite your question. For those who are online, we'll be monitoring the Zoom, and one of my colleagues, Brittany, will be reading out the question, and John will do his best to repeat it back so that everybody has the benefit, whether online or in the room, to hear what the question was. So as you're formulating your questions, John, maybe I could just, if you don't mind, I could just kick off with a question of my own. I wonder if there is, sustainability is inherently a temporal concept, right? So it's not this moment. It's for something to be sustainable, it is temporal. And I wonder if this has come up in some of the discussions you've had, that in some ways healthcare could be reactive to the needs of this moment. We have a hard enough time planning or projecting for the needs of the community in 10 years' time or 15 years' time. And if that actually may be some of the pushback that you're hearing, is that it's not only the needs we have right now are overwhelming enough, thank you very much, which is, I think, what you've been hearing partly, but then also something in the way in which we understand health and we understand healthcare as in the moment, and struggle with bringing this broader vision of health over time. So I just wonder if there are any thoughts that if that temporal dimension has a place in some of this.
I think it's I think because you were right here, I think everyone here heard it, so I won't repeat that point again. But on this idea of the temporal dimension of this objection and also just doing sustainable healthcare, I think it's a totally legitimate objection in terms of people just being run off their feet who are offering incredible services to people and just trying to find time in the day. So I think we have to take that seriously. We can't just throw that out. I think some of this, when it comes to the temporal element, it's a communication problem. So actually making space for all the stakeholders to understand what the long-term goals are, how this is being mediated in a way that could be, in fact, sustainable in another sense for the healthcare workers or the patients, taking into account and addressing people's anxieties about the fact that, well, maybe I have a incredibly imminent health concern. I don't have time for some sort of environmental long game to take place for sustainability. So it seems to me that part of the problem that might exist there is, let's say we have a long-termist attitude to sustainability. How do the short-term, immediate pressing needs and enriching that conversation? I don't think I have too many more granular thoughts at this point on that, but I think that's 100% a really important thing that deserves a lot more attention.
Dr.
Yeah, can I pick up on that? Because I feel like you're answering the temporal question. There's two different meanings of temporality that are entering into this. One, which I think, sustainability is about intergenerational justice. It's actually about going forward in our thinking about what we owe to each other. It's one of its core features. There's time as in, do I have enough time right now? But there's time as thinking about health, not as something we adjudicate in the moment, but something we adjudicate over time. And so part of the objection, or part of the way you've managed the soft exceptionalism response, doesn't contest our reading of health as in the moment is the only time when we adjudicate. Never mind, I don't mean busyness, putting the busyness question away, but just health as a phenomenon that is built over time, and where our obligations with regards to health are not just in the moment. Pregnancy is a great example of that, making decisions that are not just in the moment, that are sort of future oriented. There's also some things we do in that way. So it's grappling with rethinking commitments, expectations, and practices around thinking of health along a different temporal dimension, both our own, but also, I suppose, it gets into the wider population health kind of question. But I have other questions, but I'm gonna go with that one to see if that resonates at all.
I think it's important. I think my brain is trying to sort through the different aspects of temporality right now. One of the things that you, if we're thinking about these different ways that temporal, what it can mean in different ways in healthcare, I wonder if one of the things you're referring to is the fact that if we do look at something like reproduction and future generations, even in the most basic sense, for example, some researchers have argued that assisted reproduction and resources associated with that, well, we shouldn't spend any of those resources at all. So that would completely eliminate a next generation in a temporal sense for people that would require medically assisted reproduction if we did not allow it. So on the basis of sustainability concerns, in terms of the having to marry together concerns that are immediate versus long-term or even medium-term health between individuals and not just all of society, but different groups, I think it's tremendously complex. And trying to suss out what some of those interests are and how they're affected by these different temporal concerns, I think is a project that still remains to be properly investigated by philosophers, but also a number of different disciplines. I do genuinely agree with you that this is not actually something that one discipline can just solve. Philosophers can't sit in their chair and just solve this all at once. I think temporal considerations, I mean, I'm almost going to struggle to get my head completely around all the possibilities right now, but if you think of other additional questions, I'll definitely aim to try to answer them. I hope that's sufficient.
We're just inviting you into our own conundrum.
No, it's good. This is the, yeah.
So I think we're going to jump to a question online, and then we'll come to the one in the room.
Thank you.
Related to this conversation, we have a question here. Is there an argument to be made that by not addressing climate change, we're contributing to the increase in patient volumes, which essentially will overburden our systems and ourselves? I refer to this, as Caitlin points from Unity Health Toronto, as the circular error formula effect.
I think so. To just rehash that point, this circular point about the fact that by not addressing sustainability creates even more patients, that further overwhelms the system, and it keeps going on. Yeah, I completely agree with that. So it has to be dealt with as because of the multifactorial impacts that has. So by not becoming sustainable, we pollute the environment. By not dealing with climate change, both that pollution and the climate has more negative health impacts, and that makes things worse and even less sustainable. So I don't disagree with that at all. I think it has to be dealt with. Is that the nature of the? I wouldn't object to it. Yes.
Just on that point, not my question, but it's interesting how these long-termist attitudes, both towards health and the environment, cut it both ways. But I mean, it's like you can make an argument that, well, we don't deal with dealing with the environment now is cost-effective, adding to the future because we're doing something that's essential, right? people in technology can also argue that, well, if we don't work on these, AI platforms to prevent readmissions and optimize patient outcomes, well, that is shooting ourselves in the foot as well. And so I think that there's this way that people push this into the future that really can't be adjudicated with the poor data that we have. There's just never going to be a resolution with any kind of statistics, I don't think. And so, my question, thinking about the president, you talked about this sort of, if I understand you correctly, you have a sort of endorsement of a soft exceptionalism position, where it's important to think about the way that healthcare meets health needs, right? So I'm wondering how you think about this idea of needs, and in particular, how they change and evolve over time, and how they are also differentiated geographically by geopolitical position and that kind of thing, such that it's possible. Toronto to talk about the need to get people back on their feet for cardiac surgery within a week using a robotic platform. And it's also possible to talk about the need for sterilization in gun or something like that. How do you think about needs in this objection?
Okay, so it's a great question. It covers a good bit of territory. So to summarize, I'll try to do my best. There's a couple dimensions going on there. One is the fact that we've got the immediate and the future, including long-termist. I want to just say that long-termist can mean so many different things in debates. You can have ultra long-term. There can be immediate. That's a whole other definitional issue that we need to look at. So there's this tension between the two. There's also the fact that we've got different technology futures that we're trying to navigate here in terms of the possibilities that might happen. So is there some sort of technological imperative that then will save the day or not? Do some of these different technologies, whether it's AI, it's worth, in other words, using up some of our environmental destruction now to save the day later? We didn't even really get into AI very much on this. So that's, I think, what I wanted to just, as part of that, how do we negotiate that? I think one of the things that we're thinking about for the long term that I've not introduced is that there is another dimension of this involving adaptation. I've talked to Professor Miller a little bit about, well, she's actually really put it on my radar, some of the catastrophe literature and whether or not a sustainable healthcare really needs to build that into our discussion. And I think that might be something that I would want to look at more in that dimension to your question. But in terms of the soft exceptionalism and my other initial principle, which I didn't want to talk about too much today, but just as an idea of how we might negotiate that decision-making process, I do advocate for a pluralist position that would take into account a range of different needs. I don't think you can have a one clear cutoff for obvious reasons of what a threshold for everyone's carbon kind of credit or sustainability credit because of the different kinds of health needs that might exist. So I do look to an idea where we can remove what's not necessary and what's not necessary for both medically and for people's goals in life to flourish, and get down to that need, and then provide treatment that would deal with the kinds of recovery times in the short term, but also weigh up their long-term. I have a pluralist response to it, is what I was.
I guess just to draw through with other literatures, to establish a basic standard of living in the West right now, using the technologies that we have, to meet those needs. It's simply not sustainable. So some kind of transformation of needs and how we understand those needs has to happen. That's understood in transportation, in energy, in buildings, and all that sort of thing. So just interesting to think about how that might need to occur in healthcare without being too paternal.
Yeah, so this idea of how exactly we either rethink what our needs are, or there's quite a large literature from other areas of philosophy that is not necessary. Well, put it this way, if we think about the climate change literature, even outside of sustainable healthcare, there's of course quite a lot of political philosophy that's being brought in to think about things like sufficientarian approaches to addressing needs. It is an ongoing debate, both just regularly in philosophy, in climate change, but then also that is being brought into sustainable healthcare in relation to climate change. So I think it's ongoing. It's a kind of difficult philosophical question generally about what the nature of needs are, but I completely agree with you that there needs to be probably a renegotiation of that. Thank you.
We'll do another question online, and we'll come.
Okay, perfect. This question as a bit of background, so I'm just that first, and then I'll say the question. There is a fundamental conflict between medicine and the environment. You mentioned medicine is a one-on-one doctor and patient focus, but the negative impacts go beyond that relationship. Just in pharma, the raw drugs are manufactured, let's say primarily in India, but then consumed in the UK and North America. This means that India gets the environmental burden and we get the medical benefit. However, due to the high drug use in North America, it is driving the risk of antimicrobial resistance, which if left unchecked, can become the #1 global health risk in 2050, well above cancer. No, here's the question. How can medical bioethics square that circle, i.e. the hyper-focus on patients and their rights, but create a tragedy of the common impacting everyone else? No small question.
That it's so the question has just come through. It's just really put their finger on one of the tensions here. So the idea of the fact that we have an ultra focused, patient focused approach in medicine, and how does sustainability come into that for some sort of rebalancing of aims and projects. And of course, it goes back to some of the other points about interests and needs amongst others. This is to a great extent also an environmental ethics, a long-standing environmental ethics question, despite the fact that we put a lot of new banners and labels on this. I think that how we rebalance that in terms of having an ultra patient focused approach is one of the main questions that we need to have now. So we've also, it is worth saying that we've seen a shift from the ultra autonomy approach following World War II to relational autonomy to, again, that's splitting off into various other species of autonomy and balancing. I think how sustainability fits into that kind of new ecosystem of balancing, no pun intended, is where the work needs to be done actually in bioethics right now. So I'm actually delighted that all these questions come forward. I hope we can all link up after this and continue this conversation, but I completely agree that that is the dilemma right now, how we approach that. I wish I had an answer for you of exactly how to do it.
Well, I would say to the credit of the question and
Yes.
to you as well, I think it's starting to be recognized that bioethics began very expansive and narrowed very quickly in the early 70s and became it's sort of in lockstep with biomedicine.
Yeah.
And if biomedicine is being challenged to think differently, different mindsets, bioethics is also. And so, shout out to you for actually being part of that, trying to imagine or think differently about this. We have another question from her.
Thanks. And I'm Edward. I'm a doctoral candidate here, but also work as an emergency doctor, so I find your arguments really interesting. My question is about the degree to which healthcare is decoupled from health exploration. And, I guess I'll structure my question as, if the goal of healthcare is to promote and protect health, should the focus be on health instead of healthcare? And if we accept an exception, should it be based on the function of promoting health rather than industry sector-based exception?
I may need to get you to clarify further. So the point here is to some extent a bit of a conceptual point to start between health and healthcare. And how did you put it? The decoupling between, can you repeat it again?
Yeah, like a concrete example would be, I also study pharmaceuticals. A lot of what's called innovation has marginal benefits or is even down. So that might fall under healthcare, but is neither, in some ways, in some cases, neither improving health nor improving the environment.
So I think to begin with, what I would say is I view healthcare. So I found that the issue of just defining this and sorting it out, it's a really important one. And so I appreciate your question. So I'll try to be as succinct as possible. So you have the activity of healthcare, providing healthcare. And so that's a service. And then you have got goods as well. So it's a goods and service area in terms of when we think of healthcare as a commodity. So we'll start with that class of things. And within that, you can have, the outstanding miracle goods and services. And then you can also have some that fall under the category you're talking about of maybe negligible, if not even harmful outcomes. So that's how I would sort that. How we then apply goods and services to actually get health outcomes, like the outcome of health, is a separate question. And then I think what's important is that in addition to just looking at these two things, there's your health, and then there's also all your other projects that are linked with your health in your life that you might view as being, whether or not you live a good life might be contingent on having the health, but not completely required. So not necessary, but in some cases could be sufficient. That would be the conceptual explanation I would give in relation to that. Is that relatively clear to begin with? That's how I'd sort it out. But thank you for your question. That was a good one.
Okay, so we are going to have to leave it there. So John, I wanted to say thank you so much for, obviously, we're prompting lots of questions in the chat and also in the room. So that's sign of a really great talk. So thank you so much. I want to, first of all, thank all of you for joining us as well to today's session, both online and in person. And then finally, to let you know that if you want to continue to lean into some of these challenges, the Collaborative Center is hosting its next event, looking at, it'll be time. Is there a slide for this one? I think. Here we go. This one, again, on the theme of sustainable healthcare. This one is going to be picking up a theme related to choosing wisely, which was an initiative that is an initiative about if we should not be doing things for which we don't have any evidence, and yet that we continue to do so in our health system. So both an opportunity perhaps for a little bit of critical reflection about what we're doing within the system, but then also an opportunity to sort of think forward. And this will be with Dr. John Bonning, who is an emergency medical physician, so picking up on colleague in the room. So so what I would say, thank you to all of you for joining on behalf of both the Collaborative Center and the Joint Center for Bioethics. Thank you for being here, and thank you, John, for joining us, especially joining us here in person in Toronto to share your thoughts and your research. Thank you.
Thank you.